Digital Health with HIV Scotland. This is going to be a question and answer to a panel. We will be taking questions from the audience throughout, so just put them into the chat in YouTube, Twitter, or on Facebook. If you are experiencing any technical difficulties, we are currently recording the session, so you will be able to come back and check in later. I will now introduce you to the panel. Our first member of the panel is Dr. Steve Bagley. He is a consultant in sexual health and HIV clinical director for eHealth for NHS Grampian. He's recently been appointed as the chair of clinical eHealth leads for Scotland. We also have Fraser Searle. Fraser is a member of HIV Scotland's Community Advisory Network and is a trustee at Positively UK and also volunteers with UK Gay Men's Health Collective. Our final member of the panel is Jeffrey Hirono. Jeff is responsible for the research that informs HIV Scotland's work. In particular, Jeff explores inequalities and that drive negative health behaviours, including HIV-related stigma and factors which create and reinforce barriers to HIV testing. I am the host for this evening. My name is Heather Cumberland. I am currently the Community Engagement Lead for HIV Scotland, and I also am a trustee at Hoopenny Health and Wellbeing Project in Glasgow. To start this evening, we are going to discuss a little bit about the digital health brief. Jeff, can you tell us a little bit about your digital health research that you conducted?
Thank you, Heather. Yes, absolutely. So the digital health briefing that we published earlier this month came from the views and experiences of people living with HIV in Scotland. So the digital health research and the data that we collected is part of a larger research project that I led on called the National Patient Survey. And what we did, we wanted to collect the views and experiences of people living with HIV in relation to their mental health, aging with HIV, primary care, and their HIV care in Scotland. And we did this by training peer interviewers to help conduct face-to-face and over-the-phone interviews. And the whole aim of the project is to influence health policies in Scotland, but also to deliver practical solutions to the challenges that many people living with HIV experience whilst engaging with services, including their HIV care. So one of the themes we wanted to raise during the interviews was digital health. Although the term itself, digital health, is quite broad and can include many approaches and technologies that deliver HIV, that deliver healthcare, we asked predominantly about telehealth, where GPs or HIV clinicians provide their services remotely. So we wanted to gather people's overall thoughts and experiences engaging with these types of digital health services, or if they haven't yet engaged with it, if they had any concerns about using it. So overall, our research does suggest that people living with HIV are inclined to using digital health services, not as a replacement to traditional face-to-face appointments, but more as an additional option. So although in some cases people did express their preferences for remote consultations as their primary route to access their HIV or other healthcare. So based on the data that we collected, the number one reason why people would rather use digital or remote services has to do with the barriers that people experience in accessing face-to-face appointments. So, for example, nearly all participants who live in remote communities reported that they experienced significant barriers in attending their HIV appointments. Many stated that they were reluctant to travel far distances, for example, and nearly all reported that they were dismayed by the financial implications of having to pay for travel, like taking a ferry or a train to the nearest sexual health or HIV clinic. Others, for example, reported that they were fearful of accessing face-to-face services. Although I don't think fear is a term most people will use to describe attending a routine appointment. And I suppose this would depend on why people are attending, but for many people living with HIV, fear can be an everyday experience and can be a powerful motivator to not seek healthcare. So there is quite a lot of evidence for this, but the fear of stigma and discrimination and the fear of, let's say, an accidental disclosure of one's HIV status can discourage someone from seeking health services. So tying this in with digital health, although people do recognize that digital health services may not necessarily address HIV-related stigma per se, there is a perception that by using remote services, stigma is reduced merely by the fact that they will engage with less people, such as the receptionist or other non-clinical staff at a GP or clinic. And as far as the fear of disclosure, this was especially relevant for people living in remote communities, where just the mere fact of going into a sexual health clinic may accidentally disclose someone's status. So the fear of perhaps a family friend or a neighbor seeing you entering a sexual health or HIV clinic, and then the assumption is made that the person is HIV positive. This can have a significant impact on health-seeking behaviors. I mean, there are also other issues that are reported as well. I won't go into much detail, but for example, some participants reported operational issues in accessing face-to-face appointments. Although this is mostly reported when trying to access the GP services, many participants did note that it was just too much of hassle to secure an appointment time with their GP. So they either delayed their care or just chose not to book until their health deteriorated. So in general, these are some of the major deterrents for optimal health for people living with HIV. I feel that digital health could provide some of the solutions to the challenges that, quite frankly, many people living with HIV are experiencing. It is amazing, though, that in Scotland, we have exceeded global HIV targets, but there are still major concerns, and there is a clear indication that people living with HIV are falling through the gaps and not accessing traditional healthcare. So I think it is important that people have multiple options to engage with health services. And I think digital healthcare can be one of those options. And I'd be very interested to find out more from our great panel here about what more we could do in the digital health space in order to ensure that people living with HIV can lead healthy lives just like anyone else. So yeah, this is just a very brief summary of some of the findings that was discussed during our interviews. And whilst there are challenges and opportunities presented in the brief about the implementation of a digital health program, I believe we will be discussing this later on in the session.
Thanks very much for that, Jeff. We're going to move on to talking about technology and Scotland's digital health strategy. Steve, as the Clinical Director for eHealth in NHS Grampian and the Chair of the Clinical eHealth Leads for Scotland, you may be best positioned to answer the question, how is technology being harnessed and employed to deliver healthcare in Scotland? And is there a strategy that's being followed?
Yes, there is a separate digital strategy that covers all aspects of digital tech in Scotland, and then there's a digital health and care strategy, came out in 2018. You can find it online. But I think it's important that we see IT as a way of enabling better ways of providing care, and aligning with a thing called the clinical strategy, which again you can also find a clinical strategy for Scotland online. You can read through that. So basically, what it's all about is in the clinical strategy is reducing the need for people to have unexpected care, sometimes called unscheduled care, like I need to go to A&E, and suddenly you need to do that in an unplanned way. The idea is moving that more to sort of planned care. So you've got a scheduled appointment, which may be a remote one, it may be face-to-face. And then the second step is to move some of that planned care to supported self-management. So in the digital space, that would mean giving people more tools to be their own health, access to results, correspondence, a way of asking questions easily. And that would be, that's another important step of this. And then moving beyond that is moving from self-management to prevention. So again, using tools that are available to prevent either people becoming ill in the first place, or to prevent complications occurring of whatever condition they might have. So the digital strategy is very much aligned to the clinical strategy and follows those themes.
Thanks very much for that, Steve. Fraser, you have worked in public health space for about 30 years and in many capacities are active in HIV charities across the UK. What are your thoughts on digital health? Are there any challenges that are lying ahead?
Thanks, Heather. Yes, I mean, because I see it parallel with other conditions, because I've worked around other health conditions as well as HIV, and also many of us living with HIV have other health conditions. I think, like with everything, one is access is a key thing, and how comfortable one feels using technology. I think younger people are much more active and much more keen on using technology than older ones. Certainly, as I get older, I find it more challenging getting used to doing things and learning how to use technology. So I think it's how comfortable one is with it and how safe one feels with it too, because privacy, and for a lot of people living with HIV, confidentiality is really important. And I think that's the same actually for most health conditions, because although HIV carries has a large part of stigma, a lot of people with diabetes, heart attacks, all sorts of things feel stigma related to their health conditions as well. So I think it's about how secure we feel about using digital health. Who's going to find out that we're using it? Is that message and the communication secure? For example, this conversation is being recorded. That's fine because we've all planned that and it's part of something. However, someone might be taking part in the consultation and they might be concerned that it's being recorded and might be used against them later at some point. So it's that sort of thing that needs to be taken into consideration. That's one key thing.
That's a really, really good point, Fraser. Thank you for that. We're going to talk a little bit about digital health infrastructure. And Jeff, I know that you mentioned that people living with HIV in rural areas experience barriers accessing digital healthcare. Could you elaborate a little bit on that?
Yes, absolutely. Thanks, Heather. Yeah, based on the information that we gathered in our research, it is quite clear that people living with HIV in rural or remote communities can find accessing digital healthcare more challenging. However, let's put HIV aside. People living in remote areas of Scotland, regardless of HIV status, do find it difficult to access reliable broadband, should they even want to engage with such a service. So although broadband coverage has increased significantly in recent years, there are still many areas where broadband speeds are inadequate or where mobile coverage is poor. So interestingly, I recently read a report by Ofcom, the UK's communications regulator, that said that between 6 to 10% of premises in Scotland still struggle to get decent broadband services or connections that provide at least 10 megabits per second. So this is not to be confused with megabytes, because 10 megabytes would be okay, but still quite slow, particularly in rural areas of Scotland. So by any standard, that is an incredibly slow speed. Like, I wouldn't be able to stream Netflix, let alone like video conference my GP. So yeah, this is definitely a challenge for people living in remote settings, and especially for those who are looking at implementing digital health infrastructure. I think the powers to be who are tasked with the implementation of a digital health program in Scotland definitely need to ensure that there is ongoing commitment and investment from decision makers to make a successful digital health program a reality. So this is a good question, because it actually brings me to a second point. It's obvious that investment is needed to deliver an effective digital health infrastructure and to be able to mitigate the risks of implementation failure or investment loss. So working alongside telecom service providers, or ISPs, internet service providers, will be critical to ensure widespread availability of reliable internet network, which is affordable as well. So the briefing does say that although satellite internet is an option for many people that are living in rural areas of Scotland, it can be still quite cost prohibitive. So working alongside government and internet service providers is critical, essentially, to ensure maximum coverage and to possibly help drive down the costs of internet for most people. So also, another one of the challenges that was brought up was that not everyone has access to a laptop or a smartphone. So having an internet capable device is clearly a requirement to access digital healthcare. So yeah, implementing a digital health service is, from what I can tell, is a multidisciplinary exercise where we'd ideally see a partnership between the government, the health sector, private companies, and even in this case, like third sector organizations to help promote it.
Yeah, thank you, Jeff. Steve or Fraser, would you like to add anything to that or comment on anything that Jeff has mentioned?
Yeah, I could comment on that. So digital exclusion, which I suppose is the real concern here, is a very pressing concern of many groups in the government and of many clinicians and social care third sector organisations. And the digital strategy that mentions, so not the digital health one, the kind of national digital strategy, that's being refreshed with a particular focus on digital inequality. And there's been a piece of work called Connecting Scotland, which some of you might have come across, which is particularly aimed at reducing digital inequality. And that's going to be picked up and sort of expanded with the national digital refresh that, as I say, is just kicking off at the moment. So there's lots of things that are already happening. We're hearing examples of when people get a local authority flat, they get given a tablet, for example, as part of the package. There's examples of free Wi-Fi in some urban areas, and that's certainly something that could be expanded. There's for video consulting, where people maybe haven't got broadband in the house. Highland has set up a network of places you can go to do a VC. So yeah, you don't have to have it in your house. You can go to a place in your community. Now, of course, that raises questions about how that happens in practice, and people may have questions about what else it's being used for, and soundproofing and so on. But that's easily addressed. And one of the findings from the recent equality impact assessment on video consulting in Scotland, one of the things that emerged was patients concerned about soundproofing in their own house, and they didn't really have a private area. So a lot of these digitally sounding things have very analog, kind of non-digital aspects to them, such as your neighbour hearing you when you're on having a VC or phone call with your doctor. So there's many aspects to this, but infrastructure is key, whether that's networking infrastructure or it's a bit of kit that you've got, and everything in between is absolutely key to make this happen. But there are also lots of ways that inequality can be mitigated.
Thank you, Steve.
May I come in a wee bit? I agree. I'm in a new build, and I'm just getting used to the sounds of my neighbours, and I'm wondering what they can hear with the echoes. And I concur, because I've lived in some places where you could hear the people underneath painting the walls. So you imagine what it's like for many people. And also, if you're living in a hostel or somewhere like that, it's much more challenging. And I think about for the demographics, some people living with HIV, certainly that I come across through the work with Positively UK, some of our clients are in quite extreme circumstances and poor living conditions. In terms of COVID, really emphasised digital exclusion, I think. And there's a lot we can learn from it. One is making sure if we do give people tablets and everything, that they're trained in how to use them. Because I've worked a lot with older people in face-to-face projects, and people say, yeah, this technology is great, but I need someone to keep reminding me how to use it, because it takes a while to get used to it. So I think it's great we're having these initiatives as well. And also with technology, some people will use it, and I think it's good to use it as an opportunity as well to free up so that the other services are better available for people, so face-to-face, because some people will never have the capacity to engage with technology for various reasons. They just won't. And so therefore, I would say that's great. We have this solution for the many, and then we have specialist services for those that can't access them. So shouldn't be an either or in any case. It should be a both or all of them. We work out how we do it. And that, and also ensuring people don't realize it's not trying to do things on the cheap, because people feel disrespected if they think that they're getting a second-hand service, and actually saying it can be much more convenient. Certainly during lockdown, I've used a lot of the digital stuff that's been available, particularly from HIV Scotland, but also from other organisations, which have been incredibly helpful for combating me being isolated and lonely. Because I was working in London the first part of lockdown, based in London, and then I was back in Edinburgh during the second part. And it was actually working from my bedroom in both places. And it's just really, really challenging. So being able to connect with people across Scotland was absolutely brilliant for me.
Yeah, thank you for that, Fraser. That's really good to know. We're going to talk a little bit about information sharing. So for many people living with HIV, as we've discussed already, is maintaining confidentiality and their personal health records, including their HIV status. As many people begin to use technology to access digital health services within the NHS, will the NHS ensure that people's health records and things such as their HIV status or other sensitive data is safely stored and confidential? I think maybe, Steve, you're possibly best placed to answer this question.
Yeah, I mean, in terms of data, whether it's someone's HIV status or another diagnosis or a test result or a piece of history that was given that was sensitive, it absolutely needs to be kept safe. There is always a slight tension though between using data to do good and keeping that data protected. And at one extreme, you wrap it, stick it in concrete, chuck it in the sea. Another end, you stick on the side of a bus or a BuzzFeed kind of news story or something. And neither of those are any good. It's got to be somewhere in between. Increasingly, we're trying to move away from talk about data sharing, information sharing, to information access, controlling access to it rather than sharing, because it kind of sharing, as if sending somebody something, have a look at this. It's a slightly leakier concept than saying, okay, you're our trusted person. We're going to give you access to certain amounts of information because you're involved in this person's care in some way. And increasingly with systems, we're trying to use the access approach rather than sharing. There are some kind of edges to that, because many people with HIV have very straightforward care requirements, and a small minority have very complex care requirements involving many agencies. And quite how we deal with the more complex scenarios involving social care, third sector, sometimes even the police. I mean, we can't just give everybody access to everything. We'll be very, very selective there. So that's that's an important aspect of this. I think what will make a massive difference is when we can start giving the patients access to more of their data, including a note of who else has access to that data and who else has accessed it. And we're starting to get examples of this coming through. Not many in the UK, but there are a few, and I would the kind of vision to aim for, where the citizen can almost determine who can access the data, and making an informed decision on that, because obviously there are downsides with walling it off, and they can then see who has accessed it. That would be probably the way we need to move to, and when we're making tiny steps towards that at the moment, but that would definitely be the longer term plan. And just to add that, I mean, on a more practical level, people can be reassured that breaching data privacy regulations is a sackable offence, and people are sacked for it, whether that's in a hospital, in a GP practice, or in any other application care provider. It's very rare that happens, but if it ever were to happen, then it's taken extremely seriously, and people have been sacked where that has arisen.
Thank you very much for that. Jeff or Fraser, would you like to add anything into that from what Steve has said?
Yes, I definitely would like to feed into that, and I do agree with Steve. Like, everything he said is like spot on. But it is a good question about confidentiality. There are definitely, based on the briefing that I led on, there are definitely data security concerns among people living with HIV. I mean, especially given the sensitive nature of the information collected by health professionals, like HIV status, CD4 counts, and so forth. I do think people want a sense of ownership of their own personal health information, and this means ensuring that they know exactly who has access to their information and why they need access to it. So without a uniform approach in how patient data is stored and shared, this can essentially become a nightmare for someone living with HIV when the unexpected, and hopefully it never happens, a leak or a data breach happens. So I do think it is critical that, especially as we move further into a digital health space, that there is a need for, let's say, like a digital data standards, which could potentially outline how, when, where, and why we store health data, and what protections are in place to ensure the confidentiality of people living with HIV and their health records. So this kind of goes hand in hand in ensuring that health staff are trained on handling sensitive information as well, and how to store it safely in a digital format. I mean, health data is stored digitally anyway now, but the concern is that people living with HIV want their health information safeguarded from the people who don't need to know.
I'll just add a wee bit, and I think it's important as well to ensure that there's training across the board. So I've worked in the NHS in the past, primarily in England, and then I public health moved to local authorities and worked in local government. And recently we were discussing, one of the directors talking about being the Caldecott Guardian. I knew what that meant, but my colleagues didn't, who've been in the local authority all their lives. It's this whole thing around making sure as things transition that people are aware of how data and what information is supposed to be stored. Often we forget that the whole staff team need to know about it, and everyone needs to know, because often people just think it might be the clinician and clinical staff need to know, but it's admin and anyone and everyone who's involved. So it's making sure that information is shared, and also volunteers within clinics and everything as well. It's making sure that everyone understands why data needs to be protected. And also, I think if we personalise it and make it so people understand, imagine what had happened if your data this was happening to, then that's making it real. So it's giving people real examples. And I think, as Steve said, if we hear about people being punished, for want of an extreme term, for doing it, but breaches, it'd be good to know about it and hearing about it, because you don't really hear about it. And I think that would reassure people, because often, for many people, my experience, having been a peer mentor, experience is based on often from stuff in the past, what other people have told them, and they haven't heard the good stuff that's coming out as well. So people often hold on to bad things rather than good things.
I mean, hopefully you don't hear about people being sacked for breaching data, because it doesn't happen very often. Hopefully that's the main reason you don't hear about it.
Yeah, that's good then.
So we have had a comment in from Colin Stewart at Our Positive Voice, who has said that they have 2 or 3 clients who've been passed to them from Steve or from other staff from Frederick Street who've said they are not comfortable going to a clinic for fear of being recognised. The fear of stigma is quite high for them, and they go in wearing a mask, and this was even before lockdown. So the option of having virtual calls using the Attend Anywhere software is something that they would welcome. The OPVG have access to Attend Anywhere, and it's an excellent tool. There's an issue of digital exclusion. There's still an issue of privacy, of having your neighbours hearing, as we have been discussing, and of meetings being recorded. And this additional service is not a replacement for some who have had to face trauma of going to the clinic. A virtual meeting can be a bonus.
Yeah, shall I explain what Caldecott Guardian is? Sorry, I just realised it's like a bit of jargon. Basically, it's a senior person in an organisation that's responsible for protecting the confidentiality of people's health information and making sure that it's used properly. So it's things like, you shouldn't ever leave like a little, in the olden days, you'd have a little thing with all people's phone numbers written on and stuff like that on your desk potentially. That shouldn't be out, that should be locked away. It's that sort of type of thing. And they need to make sure that data is used properly. And all NHS organisations and local authorities which provide social services should have a Caldecott Guardian, and everyone should know who it is. And often we don't. And that's why it was quite an eye-opener at many places in local government. People haven't been aware of it because it's not something they come across every day. It's part of training. It's not their fault, and it's not the organisation's fault. It's just there's often so much to take on board, but this is pretty key. And I think voluntary sector organisations should be aware of it as well. I don't know if it applies to them, to be honest.
Thanks for explaining that, Fraser. It's really helpful. We're going to move forward just now onto the future and sustainability of digital health. And I'm going to ask just one last question before we go into the audience questions. What do you think is needed to ensure the successful implementation of robust digital health service and its sustainability for the future? I think we will start with Jeff for this one. You're on mute just now, Jeff.
How about now? So
yeah,
I think what is really needed is commitment from decision makers. I think we need to ensure that decision makers see the value in what digital health can offer and be able to allocate the resources and investment to ensure that a digital health program in Scotland is successful. Infrastructure-wise, I think it's vital that we implement it effectively in the long run. So in other words, the infrastructure will need to grow organically and have the capacity to withstand the added demand on the system, but also to be able to ensure that it can do so effectively. So what that is at a healthcare level, where staff and healthcare providers are able to be trained effectively to deliver digital health, but also in the technical aspects of implementation. So for example, will a broadband network allow for growth or be able to integrate new innovations as technology improves? Or will internet service provider be able to deliver the speeds that will ensure uptake? I think also more importantly, our community members being involved in the decision-making process. I think for us as an organization, this is a core to our kind of ethos, and it's core to the development of a digital health program. By involving people who's experienced barriers in accessing traditional healthcare, Scotland can better identify challenges and opportunities to improve the health of our most vulnerable. These are some of the questions that need to, I think, be asked.
Yeah, I think that's a really good point, Jeff. Steve or Fraser, would you add anything into that?
Yeah, I mean, for me, in my experience, we talk about the kind of wires and the boxes and the kind of really techie bits of digital health, but the things that really make it a success or a failure are the two things. One is designing the service well to start with. So we're involving everyone who's going to use it, clinicians, admin staff, patients, anybody who's involved in the service, so in a good design. And the second thing that makes it fly or fail is supporting the change process. So you can't just kind of design it, put the boxes in the wires and whatever software and walk away. You've got to support the change. And often we cut corners with design and service and change management, where you kind of focus on the shiny bits and kind of assume the rest will happen and assume that a kind of software product which works somewhere else will just slot into another place and work seamlessly. So for sustainability, you've got to deal with those things, and that does require investment. But I think the way to sell that investment is through a thing called the productivity paradox, which some of you might have heard of. It sounds like jargon, but it's kind of common sense in a way, in that we often introduce IT to something to improve it, but often what ends up happening is we just have what we already had before plus an IT cost on top. That's because we haven't actually we're not actually doing anything better than we were beforehand. It's just costing more. But by designing a service well and promoting and supporting change well, it then allows us to not end up costing more, and that in turn makes it more sustainable, because we can't ignore the money. Has to be within a manageable sort of funding envelope, and we can achieve that by designing well and supporting change well.
Thank you.
I'd say, and ensuring there's maintenance and continued development in there as well, because I've been involved in stuff where you've introduced something, but actually the budget for maintaining it and improving it's not been there. So it means it actually falls by the wayside, and also the training to ensure that whoever's got to maintain it is able to do that too, because things just don't happen. It's a bit like professionals. You need to keep things up to date, and likewise with the technology, it needs to be kept up to date all the time. And I think Steve's right. It's about thinking about the costs and not expecting stuff just to slot in. So I always think it's getting someone on your side who understands the IT, and not necessarily someone who's from the sales side, because I know nothing about IT. It's not my specialism. And I can be told all sorts of things, and so it's that sort of thing. So I'm trusting someone else, and I need to be trusting. I trust someone a bit like as a service user. I need to trust the organisation that they will look after me as well. So it's the same when you're buying something in.
Yeah, I think that's a really good point, Fraser. We are going to move into questions that have been sent in to us from audience members. And the first one is, how do we ensure any move to digital healthcare more permanently? Are there extra resources available for communities most at need, or those who are digitally excluded? I feel probably, Steve, this is one that's quite suited to you answering.
Yes, I mean, I covered this to an extent before, talking about the digital strategy and the need to reduce inequality there. Lots of work underway looking at different models and providing devices, providing places for people to go to. And I mean, I think what we need to start thinking about is seeing broadband as a utility. You wouldn't move into a flat that didn't have water or electricity. And in the not too distant future, the idea of walking into a property, a local authority house, for example, that didn't have broadband, it'd be like I don't know, arriving in the 19th century or something. It'd cause similar consternation. So we need to get to that as normal. Clearly, even with that, you need the device to connect and all the rest, but there are ways to deal with that. And I think the ultimate safety net, because we're talking about people who have houses to live in. I mean, not everyone. A lot of people who don't have a house, either because they're homeless or because they're travelers, maybe. So we need to provide service for those folk as well. And there probably always will be a need for a physical place you can walk into that may be 50 miles from where the doctor is or the nurse is that you're talking to, and sit down and have a video consultation or even just a phone call with that person. And that would probably be the one of the safety nets. And of course, choice is essential to maintain as well. I think we need to maintain informed choice for people, so they can choose to physically walk into a building and sit down and talk to somebody, having weighed up the pros and cons of that in terms of catching a bug on the way, or when they're in the building, or the hassle and time. So for some people, that is worth it to actually do that.
Yeah. Fraser, would you have anything to add into that at all?
Just say, I think it's an important point. It's having that awareness and always reminding people who are planning that actually this isn't accessible to everyone, and having the conversation with the people or individuals who aren't able to access it. What do you need to help you? I think that's key as well, because if you know about things already, that's fine. You forget that other people can't do it. So I think it's having the conversation and asking and checking who's not being engaged is pretty key, and why, and the why is, and how do they think we can solve it? Because people often have the solutions themselves and what they need. So I think that's a good starting point.
Yeah, definitely. Our next question is, how are we ensuring that digital health services are accessible in rural or remote communities across Scotland? Now, I think obviously this has been a recurring theme that has come up throughout, and there has been definitely, this has been touched on through what you have been saying, Steve, as well as what Fraser has mentioned. But do you have a direct answer for that?
Well, I mean, I don't want to just kind of repeat stuff I've already said, but I suppose the question is, how can we ensure that that happens? By repeatedly pointing it out that that's a problem. But I mean, the people in senior positions in organizations and healthcare and the government totally have this as an area of concern. The equality impact assessment I mentioned, which I was reading a draft of yesterday about video consulting, absolutely has that risk of rural isolation up there. But the flip side of that, of course, is that it's for someone in a highly rural area. Digital connections to healthcare providers is way better than anything they had before in terms of transport. I mean, the very first person to use the Attend Anywhere platform in Scotland, somebody with HIV living on a remote island. I mean, that's it's almost made for that situation. So as long as we can get the basics right in terms of broadband and devices, then it's a great thing. And I think that we're already seeing people moving to very rural areas because they now can live there and work and have healthcare provided in those places where previously it wasn't really a tenable kind of idea.
Yeah, thank you for that. So our next question is, are you finding that people living with HIV are more willing to engage with digital health services as opposed to traditional face-to-face appointments? And I think probably, Jeff, you're best placed to answer this one.
Yes, I think yes. Overall, people living with HIV have seen digital health as a positive thing, and this is based on the interviews that we've conducted here for the National Patient Survey. Especially during COVID too, we did not expect any form of digital health to come so quickly, but yet here we are. People living with HIV are not accessing remote appointments, but so far we've been kind of reactive to the external factors that necessitated the move towards digital health. I think this provides a great opportunity to assess digital health. So what is working, what isn't. I was speaking earlier to Steve about there's an NHS Scotland that is currently undergoing a large-scale survey to gauge the acceptability of remote clinical HIV appointments. And I'd be really curious to find out what the results show there. But from the research I've done, it looks like there is definitely a willingness to access digital health services. Absolutely.
And Jeff, do you think it's different for people living with HIV in that regard?
As in different in accessing
different than the general population with other ailments? Is it specific to people living with HIV that they're more willing to access digital health services?
I can't really say for the general population, but for people living with HIV, and just based on the briefing that we did and the research that we conducted, is that yeah, people living with HIV generally are more inclined to use digital health services.
Thanks for that.
I was going to say, because one thing is certainly, if you think about different population groups with HIV, gay men are quite tech savvy and also been early adopters. And it's one of the things, so actually, if the different demographics of people living with HIV are quite willing to take things on board. So I imagine, again, from the work, some of the people I've worked with, for if you're an asylum seeker, refugee, or women living with HIV, African women with HIV, and you don't want your family to know, it's much more difficult to engage with this, with online and your family and your home environment. But certainly there, from my out with the HIV sector, and actually I've done it, and for general healthcare during COVID, it's had digital appointments and consultations for other things. And I think it is around it's kind of brought things on in a way that we didn't expect, but actually it does make it more convenient if you're stuck for work, you can't get out of work, or you can't travel somewhere as well. I think it'd be interesting to see, particularly those of us with multiple health conditions, if we've had to do them for other stuff as well as our HIV consultations.
Yeah, I think that's a really good point to bring up, Fraser. The awareness of like being part of that and how that could potentially be different for people living with HIV. I believe this is the final question we have from the audience. Are there any other digital health tools or approaches being employed other than telehealth in Scotland? and how would these benefit people living with HIV? I think that one's probably for you again, Steve.
Okay, yeah, I mean, as I think Jeff said in his intro, or was it yourself, Heather, digital health is a massive area. I mean, it basically, I mean, I describe it as using information to improve health and care. So teleconsultations are a tiny, tiny part of that. There's way more to it than that, although that bit does get a lot of attention. I mean, we often talk about a thing called a kind of a learning healthcare system, where we're constantly trying to improve healthcare through the better use of data, and the cycle starts with using easy ways to capture data from people, citizens patients putting in their details, how they're feeling in a way that can easily be accessed, and electronic records that doctors and nurses use, and then using that information to improve care, you know, to pick up where a drug caused a side effect, maybe, or where something else wasn't quite right, and then improving the service that's provided in an ever improving virtuous circle. So that's actually quite hard to achieve, and there are in this kind of this cycle that we talk about, there are quite a few gaps at the moment, but they're all progressively being filled. Whether someone is perfectly well at home, going about their daily business, or whether they're really ill in hospital, and we're trying to find out what's wrong with them, these sorts of techniques to use data to improve care are becoming more common, although not yet kind of standard. So there are loads of different ways digital health is used. I mean, I think the other area to think about here is the overlap between health and wellness. And many of us have you know, smart watches and all sorts of things that we use to track what we do, and many of those have a kind of wellness or health element, and that there's an interesting crossover bit there between wellness, maintenance, and health, and how that data is used. So there's many aspects of digital health beyond teleconsultations, and the digital health strategy has many of those items in it if people want to read more.
Thanks for that, Steve. I don't know if anybody has anything else to add to that point in their knowledge of things other than telehealth.
I have a quick question for Steve, if I may, and it's not related to that one question. So, Steve, one of the issues, or one of the challenges that people living with HIV are reporting is that the integration between health services and what that might look digitally. So do you think digital health can provide a seamless and holistic approach to healthcare for people living with HIV?
Well, I mean, healthcare is quite fragmented at the moment. There's hospitals, GPs, optometrists, community pharmacists, dentists, and there are kind of information bubbles there as people move around. Limited amount of information is accessible depending on who you're seeing, but some of those information bubbles are starting to sort of join together in safe ways. So now, maybe one thing that's happened with COVID, for example, is that community pharmacists in most parts of the country can now see which medicines a GP has prescribed for a patient. Many medications have side effects and interactions, as you'll know, and a patient getting either getting some over the counter or seeking advice. One of the first places we recommend they go is a community pharmacist for many problems. So this was seen as a major safety risk, this lack of information to medication. But so that barrier is now starting to go, and there's various other examples there of hospital clinicians being able to see elements of the GP record, for example, and it's starting to build towards a future where there's a sort of single record of truth about a person, and if you need to see that, then you get access to it, and the patient also has access to it, and they can, as I described before, see who's accessing it and determine, if they don't want that or not. So we're moving from when we have a fragmented landscape, much less so in Scotland and England, I should probably add, but that fragmentation is starting to kind of heal as the information world starts to become a bit more coherent.
When I say from a patient perspective, I think that's brilliant, because pharmacy is the first port of call for lots of things. And I always say to people, if I got knocked over and was unconscious and got taken to hospital, and suddenly they started giving me treatments that were contraindicated to something else I was taking. So for me, that people know what I'm taking is really, really important. I know that I have family members who carry little cards saying, I'm on this. I've even got a friend who's got it tattooed, all the medication. He's got it I think it's quite extreme, but he's done that. But it's about, and also because pharmacy is often the first port of call for people who don't know how the system works and how the NHS works. So I think it's really important that they're connected. And so it's really great to hear and really, really reassuring.
In our brief, we did recommend like an integrated system that could be, so we did recommend an integrated system where health information is stored and accessible to a patient's care team. Like you said, Steve, like the GPs, the pharmacists, the optometrist, and the HIV clinician. Although I do see that there could be some implications in storing that kind of health data in one location or one system, as it could be seen as a security risk, or whether data stored in decentralized servers or what have you. But through an integrated system, I do think there is an opportunity here to see how that would look digitally. And a lot of people are, what's come out of the briefing and the interview is that a lot of people living with HIV are just quite frustrated with having to retell their HIV stories over and over again. And of course, this can be a significant barrier for many people accessing healthcare. So I think the concern here is that, like you said, was that each hospital, health service, or health specialty all seem to be using a different system. Each department within hospital seem to be using a different set of tools, or each health worker has a different way of working. So it's evident that there's a bit of a disconnect there between health services, and they're not quite yet talking to each other quite effectively. So I think what you're saying about it kind of moving into that direction where it's kind of centralized is a great opportunity.
Yeah, it's kind of moving in that direction, and there is some standardization across the country. In Scotland, I mean, there are only 2 GP systems, for example, that are used, but information doesn't flow necessarily from practice to practice. But the software is pretty similar, and there's one main hospital electronic record that's used across sexual health services. There's one system used across country. So if you're being seen for HIV in a sexual health service, and you move, say, from Glasgow to Edinburgh, then your care records, well, certain parts of it at least, can be accessible to the new service, and that happens quite smoothly. So yeah, I mean, there are many gaps, but things are starting to improve. And I think the interesting thing about how digital health would kind of look in the future for someone with HIV, as I see it, basically that they'd have most people would have an app on the phone, a web app, and I mean, I quite like the NHS app in England as a kind of starting point for this, and it'd be great if Scotland would just use that, and with some minor modifications maybe. So from that you can get to your meds, your test results, redundance. So I've got a problem and it's going to send a message, rather than it's having to rely on phone calls, emails, and things like that with patients at the moment. So I think that's kind of how it would kind of look. And obviously you could also have your phone consultation, or your video call with your clinicians as well. it's hard. It's not hard to see that sort of thing coming just a year or few away. But I think in terms of, which I mentioned before, it's very important that patients contribute to the design of that. And I mean, I'd maybe ask HIV Scotland to work with patient groups to say, what should the world be like in 2025 in terms of service design? It'd be fantastic if you could come up with a, Bob's journey in 2025. What does he do? What's it like for Bob in 2025? And as chair of the Clinical Health Leads for Scotland, I can then take that and say, look, this is what people want. We need to make this happen. So that would be my ask for yourselves.
Well, I think that's very much an ask that we'd like to be able to deliver on. Fraser, I'll let you say.
I think that'd be great, the ask. And I'd say it's, for me, one of the fundamentals is just explaining to people at the beginning. I think it's that not all the systems connect, and you might have to tell your story again would help with that fatigue that you talked about, Jeff, that people do have, because it's across health conditions and going in and you think, haven't you read my records and stuff like that? And I think one of the challenges, and what I always say to people, and it's based on, I worked in an older people's project, and they said, oh, we've done a presentation at the hospital. And I said, that's great, but you've not spoken to that unit, and that unit. It's like the United Nations, and there's all different bits to it. And some of them connect and some of them don't. Some of them disciplines like each other and some of them don't. And there's all this sort of stuff. Everyone's working to your health, but they've all got a different way to it. And it's just explaining. And I think if people understand the complexity of it, they're much more forgiving, and if they know why, you might not know their information and stuff. So it's about the individual. So for me, the digital health part's important, but also the rapport of the people that are doing it and doing the consultation. Because if you come across warm, so hence during this, if you've got a personality that can come across well during the consultation on screen, that's really important as well. Because as part of the information is good, but are you a warm person? Do I feel rapport with you? Do I feel I trust you with my healthcare is really, really key. And I think sometimes that can be a barrier. People think you can't get that through digital, but I think you can as well, because we do it all the time. We see it and hear it all the time on the radio and television and online.
Yeah.
Okay, well, I think that is us coming to a close for the evening. I want to say a big thank you to our audience who have been putting in questions and engaging with the question and answer session. And I also want to thank all of our panelists, Fraser, Steve and Jeff, and for really informing us on what's happening with digital health in Scotland just now, particularly in light of COVID, when we are having to engage a lot more with digital services. If anybody has missed any of our fantastic question and answer tonight, you can go back and watch the recorded session on YouTube. And we would encourage you to do that and share that with people so that they can see and learn a little bit more about digital health. You can access also our website and any further information on www.hiv.scot. Once again, thank you for joining us tonight.
Thank you. Bye.
Bye.
Thanks. Bye.